Hi, good morning, everybody. Now, I don't know how many people have seen cave ring, but it's not a very common thing to see. So my paper is cave ring is rather a better confirmatory sign than a serum cerebroplasmin in cases of Wilson's disease. He is Samuel Alexander Kinnear Wilson, and contributors are a lot because it's not possible to see a lot of cave ring by a single surgeon. So Wilson's disease is uncommon disease, and it's not a rare disease. And the cases go undetected. That's why this, and because of lack of suspicion and lack of proper lab diagnosis. Our aim was to find out the relation between the density and the width of the cave ring versus the lab finding of serum, ceruloplasmin serum copper, and response to the treatment was a decreasing cave ring. If you review the literature, there is inborn autosomal recessive with deficiency of alpha-2 globulin and ceruloplasmin, and results into the free copper and throughout the body. And in cases, it affects the liver, and the neurological deficiencies are there, especially the rigidity dysarthria, dysphagia, and dystonia is very, very important. The diagnosis depends on a CT scan, which shows the ventricular dilatation and hypodense area in the thalamus and basal ganglia. And the MRI shows face of giant panda, typical, appearance in the midbrain. And slit lamp examination shows cave ring. So this is a CT scan, and this is a giant panda sign. Giant panda looks like that. And urinary copper is always elevated in such cases. The copper excretion is more than 100 microgram. So this is a cave ring with magnification. This is cave ring, cave ring, cave ring. And you see the patients, look at the face of the patient. The typical, the presentation of the face. The patient is not happy. He's in agony, but then it's all stretched up muscles. And you see, he's in such a pain, and there's a psychological effect you can see. Again, the same patient, the other patient with the same kind of face. Look at the face, look at the rigidity, 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 rigidity. And look at the typical gait of the patient. So let's talk about the cave ring, which is located in the peripheral part of the descemet membrane and ends just in front of the Schwalbe's line. It does not invade trabecular meshwork. We have graded the cave ring. All suspected and new cases which were suspected to have a cave ring were sent to us, who carried all the informations about the lab. So we graded it to grade 1 was the top arc of the dense membrane was involved, and grade 2 was the inferior arc was involved, and grade 3 was all around it was involved as a ring, and grade 4 it was a wider deposition of the rings. Like this is the grade 1, this is the grade 2, this is the grade 3, and this is the grade 4 of cave ring. The severity of the disease, serum ceruloplasmin, and response to treatment was observed in relation to cave ring. In our observation, 168 cases of Wilson's disease suspect, 158 were confirmed, 14 had normal serum ceruloplasmin level, but positive cave ring. 10 had low serum ceruloplasmin level, but no cave ring, and did not respond to the treatment. Grading did not match with the serum ceruloplasmin level, but with the clinical severity. A response to the treatment matched with decreasing grade of cave ring. Patient's own evaluation matched. In all cases where the patient improved with the treatment, there was sign of regression of cave ring, and 6 cases of cave without lab test improved with treatment. We have so many number of patients in different gradings. 18 cases of grade 4 cave ring and 6 cases of grade 3 cave ring. Patients succumbed to the disease because of the non-availability of the medicine and irregular dose. So we conclude that dystonia, rigidity, dysarthria, drooling, tremors, progressive chorioathetosis, and behavioral and psychiatric manifestations enough to arouse the suspicion. Should be subjected to a slit lamp examination along with the lab investigation. Wilson's disease is commoner than what we think. Treatment should start if cave ring is present. Since 14 had normal serum ceruloplasmin level, but positive ring, and it responded to the treatment. Number 2, Wilson's disease, if it is below 10 microgram of ceruloplasmin, you confirm it. And since 10 cases had low serum ceruloplasmin level, but no KF ring, and it did not respond to the treatment. Since all cases showed decreasing KF ring with treatment, KF ring is a better confirmatory sign than serum ceruloplasmin and Wilson's disease. Thank you.
What is the duration between which you saw these 158 patients? What is the duration of the study?
It's a very long-term study. It's from 1994 till recently in May 2022. Because getting 168 cases is, I don't think so.
That's why I asked.
Yeah, it's very long. And there were so many contributors. All the neurophysicians and even the Kanki mental hospitals, they thought it's a mental case. They all referred the cases for the KF ring.
So was there an association with the symptoms also with KF ring, presence of KF ring, like the rigidity and other things? Was there any association? Was it checked?
Sir, as I showed you that there is a typical phases of the patient. There is a rigidity, there is a drooling, and the rigidity is so much that you cannot even, it is very difficult to put them on a slit lamp. Leave apart the gonioscopy. Gonioscopy is not possible. If some literature says that gonioscopy should be done, it is just not possible. It was a case of Wilson's disease.
But many times I think handheld slit lamp helps. Handheld slit lamp in case of rigid patients.
Yeah, slit lamp you can see the KF ring, but you cannot do the gonioscopy. What I'm saying is some say that gonioscopy should be done. It is not possible. It's just not possible.
For the benefit of audience, can you differentiate the clinical feature between arcus senalis and KF?
The arcus analysis in the upper part, and there's a typical yellowish discoloration of the endothelial part of the cornea in the Wilson's disease, and it is dense in the periphery, and becomes little thinner. It rarefies if it goes towards the center. I'm talking about the grade 4, because that will you'll be able to understand better. So it is very dense in the center. It spreads periphery and it spreads towards the center, and when it goes to the center, it keeps on rarefying itself. And sometimes people mistake it by the limbal yellow coloration of the limbal conjunctiva when it comes to the cornea. It's yellow, so people confuse it with that. So it is an inner part, and it never goes beyond the Schwalbe's line. It doesn't reach the trabecular meshwork.
Thank you.
Thank you
Thank
so
you.
much, sir.